vitrectomy has now a long history in eye surgery because it started in the 70s. And I was already there when vitrectomy was started. And therefore, I would like to introduce a little bit of the history because you might not know. Now you have a fully equipped technology where you have trocar systems and it's what you expect that how it should work. But at that time, vitreous surgery was very exciting because we had to learn new things every day. And the equipment was, of course, not perfect. We did not have many additional instruments. And retrospectively, I think it was the most exciting time in my life in eye surgery. But I'm happy that we have now cool systems. Once I said to a colleague, now we know everything, you know, what should be further done. And he did teach me, we never know everything. There's always something which can be improved or learned. So, the content of this talk is a little bit history, the technical development and indications we had along with this, the surgical technique, and the complication management. And I want to do the complication management for those who are doing vitrectomy or want to start vitrectomy. Who is doing vitrectomies? 1, 2, 3. And and the others, I think you are assisting in vitrectomies? Yes. So you have all the troubles. Yeah. Good. So vitrectomy was invented in 1970s by Machema and Klöti. And here is a picture of Robert Machema. I don't know if you have ever heard the name or know about him. Robert Machema was a German. He was born in Göttingen, and he was dissatisfied with the way that he was treated there. So because he wanted to do vitreous surgery, and nobody believed him, and he was invited to go to Miami, to Bascom Palmer, where Dr. Norton was the head, and he was a great chair because he could support new ideas and colleagues. So together with Jean-Marie Parel, who is still living, they two developed the first whisk machine, whisk 10 it was called. And this was actually a 2-port system, and it was quite big. And we did vitrectomy via the slit lamp of the microscope. There was actually Dr. Karsner, who was the first who did vitrectomy, open sky vitrectomy in a case of amyloidosis. And he just, you know, via the cornea opening, he removed the vitreous, and he never reported about it because he was so frightened of the aggression which might come from the colleagues. Open sky vitrectomy is still sometimes used in ROP eyes. There was a lot of ROP, retinopathy of prematurity, where sometimes it's used in Harvard, that if there is a lot of anterior pathology, but otherwise it's not used anymore. So the first vitrectomy Dr. Machema did at that time was a case with chronic vitreous hemorrhage. And it was a success. And this is message number 1. If you invent something new, then please make the first case successful. Because otherwise, they never let you do it again. So obviously there was no rebleeding, the patient could see better, because in the following years we had a lot of problems with vitrectomy. They had rebleedings, they became physical when the lenses were removed, and so on. So in 1972, Robert O'Malley then introduced a 3-port system, which we still have. He separated infusion, cutter, and light. And the cutting and suction was regulated already in a pre-setting. Now, in the years 80 to 85, we finally had endolaser. And the endolaser treatment reduced postoperative hemorrhages 75%. Until this time, in diabetic cases, they went in with light perception, and then they went out of the hospital with light perception because they had rebleeding so quickly. The indications for vitrectomy were actually only for hopeless cases of diabetes, trauma, and PVR, retinal detachment. PVR means proliferative vitreoretinopathy, and I think Dr. Falkner talked about this already this week. Yes? Yeah. Dr. Scott, Lever, and Sivojnovic in the early 80s, they now introduced silicone oil tamponade. And Dr. Sivojnovic was actually very good in doing retinotomies and retinectomies. Silicone oil was done by John Scott in Cambridge without vitrectomy at the beginning. I visited him because I visited a lot of doctors. You have to go to the kitchen to know what's happening. And Dr. Scott was pressing the silicone into the eye between the detached retina and the vitreous. And actually he could fix some eyes. It's unbelievable, and he did that with the indirect ophthalmoscope, not with the microscope. He was a very good musician, so he had great hands, and you could see that he pumped the silicone into these highly myopic eyes. And he was successful in probably 40%. But later on, of course, we learned that you have to remove the vitreous, then you can fill in the silicone, and it made much more sense. At that time, cutting the retina was something very courageous. It's also not a very, very pleasant feeling if you do it the first time. I don't know who did retinectomies, you probably did. It's always that at the beginning you think you undertreat the size of your retinectomy because you don't want to cut further and further. But if you decide to do it, then you have to be very generous with your retinectomy. And actually at that time, there was in trauma and severe PVR anatomic cure of 40 to 60%, which is much better. But it's also an anatomical cure. These patients could not really see too well. The vitrectomy machines have improved. You all know that. We have a much higher duty cycles. We have intraoperative control of flow, and enhanced light, integrated laser, automatic gas and fluid walls, and diatomy and reflux, and very nice ergonomic pneumatic handpieces. The vitrectomy handpieces did become smaller and smaller over the years. We are now at 25 or 27 gauge mainly. Are you doing 25? Yes. Yeah, I think, 27 is actually, I use it only for very easy cases. I feel that if you have a lot of vitreous to remove, it takes a longer time. So, but I use 27 because 27 never leaks. 25 sometimes, but this is a different topic. And I'm very careful that I don't get postoperative hemorrhage. So if I have a choroidal bleeding or postoperative hemorrhage, this is really very bad. In the literature, the non-stitch vitrectomies, probably 1/3 is sutured in general. So if you have three openings, in general, you have to close one with a suture because it's not really so tight. But we will discuss that another time. Endolights became much better. We started with halogen, and then we moved to xenon lights and chandelier lights and 4-port vitrectomy. And and with that, vitrectomy also became a big indication for primary retinal detachment. Who is using 4-port chandelier lights? Are you using them from time to time? Yes, I do too. It's not pleasant, but it's if you finally have the light there and you can use both hands, you realize you should probably use that more often. But we always try to get away with the routine we are familiar. We had introduced new instruments like the fluid needle. Can you explain what the fluid needle is? So it's a passive evacuation of all kinds of fluids. Of course, blood is the number one, but it's also for fluid and perfluorocarbon, whatever you might need. We have expanding gases like SF6, C3F8, and C2F6, where you have to know exactly the percentage of the mixture you are going to use. And also the viewing system has changed from lenses to the biomes, where we now have wide field viewing. In 1979 to 2002, silicone oil studies were published, and this is also very interesting. They were published in the American Journal from Duke, and what they said is that in anterior PVR and trauma, silicone oil is superior to gas, because in America for a long time silicone oil was a bad thing to use. We in Europe, we used silicone very, very soon, and that was of course an off-label use, but nobody asked for that. And we had better experience with silicone oil than with gases. The Americans have better experience with gas. They are so used to gas. What's more important is that the best visual results in all these studies was if an eye was fixed with one surgery. The more surgery you have to do, second and third surgical cases, they lose vision with every surgery. Even though if you are able to fix it after 3 surgeries, the patient is not able to see very much except the 1 meter vision. So what I want to tell you is your concept of the first surgery has to be large enough and clear enough that the patient has a good chance that the case is done. If you try to leave something for the next, or you know, be a little bit more hazardous, and then you are not going to win. Different silicone oils are available. The most used silicone is 5,000 centistoke. What are you using? Yes, and yeah, you too. Yes, I do. It's many use now 2000 because it's a little bit quicker, but I like the control I have with the 5000. It's slow, but I see what I'm doing. In the year 85 to 90, so in 86 to be precise, Stanley Cheng introduced perfluorocarbon as an additional aid primarily for giant retinal tears. Until this time, there were several designs of tables which were rotated, that the patient in a giant retinal tear, you could inject the gas lying on your back. It was Dr. Freeman from Harvard who did a lot, I think 300 cases of this. And with the perfluorocarbon, which is actually heavy water, which sinks down in the eye after you have removed the vitreous carefully. We got rid of that, and we could flatten out the retina and then proceed with endolaser treatment of tears or whatever we wanted. Perfluorocarbon is not a long-term tamponade. It's actually designed to be removed at the end of surgery. There are several groups which leave perfluorocarbon for 3 to 4 weeks in an eye if you have an inferior retinal detachment. Because in inferior retinal detachments, to be clear, the gas is not working so well. And then the idea is if we use the heavy liquid, if the patient is upright, it will press down the inferior retina. I personally do not like it. It's inflammatory, and I think it creates more problems than in the superior part of your retina. And there are Italian groups which combine actually the normal silicone for the superior and the perfluorocarbon for the inferior retina. It's called the sandwich technique. And I don't think it's necessary. If you do a clean vitrectomy, it's much better, and you can have the silicone oil there for 3 or 6 months. And I never leave perfluorocarbon in the eye for these reasons.
Do you like heavy silicone?
No. I like it if I do a retinal detachment, or I like it during surgery, but not no. There is also, in 86, was the introduction of the temporary keratoprothesis. Are you familiar with this? Yes. Yes. Because it's really helpful in severe trauma. And why do I mention that? Because it enables us to do timely surgery in a severe trauma case. The first, let's say, 1 to 3 weeks after the trauma are the most important, because in that time, if you don't remove the blood in the vitreous, then the retina will be torn off very easily and then shrinks very, very quickly. And we tend to wait until the cornea, if there was elevation or whatever, if the cornea clears, so that they can do vitrectomy then. And then you waste time. You rather go in at exactly the second or third week, where you have better chance that it doesn't repeat so quickly, but also the retina is mobile enough that then you can do whatever you want. In these are young patients, the retina will be mobile, but it will torn somewhere. You can cut it and fix it with silicone if it's not completely constricted. So to do this device is very advisable. And I usually do this on my own. You can certainly ask the cornea person to define the cornea and future keratostasis. You have first during surgery, and at the end of surgery, you remove the keratosis and put in corneal transplant. And it works quite well. Timing in trauma cases is extremely important. At the beginning of the 90s, macular surgery was introduced in vitrectomy, and actually what we learned from macular surgery, not only that we can close the macular hole, but also how much surgical trauma we might do with our life or with our instrumentation. Up to this time, the cases which underwent surgery were such bad cases that whatever was the outcome, it was accepted. They were already, But if you do macular surgery, what you do in addition matters a lot. And we learned that if we use the light in front of the macula for a long time, you might end up with some light damage. So we were more careful not to direct the light to the retina and not to heat it up too much. There was also, at that time, the AIDS and uveitis came up, and we implanted slow drug-release systems in the eyes, and subretinal surgery was introduced by Ed Thomas. And for subretinal surgery, which is actually not a very difficult surgery to do if you have the right instruments. You need instruments with a longer angle here to reach out, introduce your instrument outside of the fovea and reach into the fovea to remove a membrane or whatever you want. But it's not so difficult. Now, in the early 2000s, there were retinal rotation techniques and retinal transplantations introduced. Retinal rotation, do you know what this was for? Yes. So it was in AMD cases. The retina was cutted in the periphery and then rotated so that the pigment epithelium defect was actually rotated and the retina was rotated on a healthy area which has not the pigment epithelium loss. Unfortunately, this was a surgery with a lot of complications. More than 30% had hypotony or macular edema, and it's used in certain centers, but not used very often anymore. Dyes for membrane peeling, and that you see in your right picture, this is at that time indocyanine green, but now we have also different blue dyes which are lesser toxic than the indocyanine green. But it helps us to remove epiretinal membranes and also the membrana limitans interna. At that time, because both surgeries were now small incision cataract and vitrectomy, the combination of both surgeries became actually a routine in many areas. And I have to say I do a lot of combined surgery. If the patient is over 60 and I have a macular case, I would actually recommend also simultaneous cataract surgery. It's not an issue. And as I already mentioned, we have now small sutureless systems which are very helpful to make the trauma of the surgery smaller. I think the small gauge systems, it's not so much about if you have to place a suture or not at the end of surgery. It's much more that you can go closer to the retina, you have higher precision and lesser trauma in general. So let's go to the basic technique. This is for those who want to do vitreous surgery but are not in this kind of surgery. You know, you have now preset systems. You use the trocars. you don't have to prepare some sutures. And what you do with a core vitrectomy, you always start in the anterior part of the vitreous, behind the lens, but not exactly at the lens capsule. You remove the first part to have some versatility with your instrumentation, and you create a cavity behind the lens. You control the light to minimize the reflexes, and you guide the instruments in a circle at the beginning. It is different than cataract surgery. So in vitrectomy, it's not like phaco. Yeah? You hold your hands very still. And at the beginning, it's challenging because you feel you need to do something. But what you need to do is to have quiet control of the situation, and you circle your instruments and the lights in 360 degrees in order to clean the anterior part of the vitreous, because sometimes it's not so well visible. And your removal of the vitreous takes time. So in general, it takes 8 to 11 minutes to remove a vitreous, independent if it's a highly myopic eye or an emmetropic eye. But you need to be prepared. You don't have to rush. You know, in cataract, usually you come from cataract surgery, you go to vitrectomy, you are used that everything is done in 3 minutes, and now you stand there and you have to wait. But you have to be patient. The anterior part of the vitrectomy can be done under the microscope, so that and then you switch to the posterior part and use the biome. Close to the retina, if you work close to the retina, you have to always use low suction and high cutting rates, which makes a lot of sense because you have to cut away the vitreous but not tear the retina. If you have, for example, a diabetic case with some traction, the rules are that you remove first the anterior posterior traction, and then you remove the tangential traction. And if you go closer to the retina, you can use some segmentation with scissors or with very small instruments, whatever you have. There is also the so-called en bloc technique by Maria Berrocal from Puerto Rico. Yes, thank you. And so she chose a different approach. She did leave the traction. She opens the posterior vitreous in front of the optic nerve, because this is the safest place for a diabetic patient if you are in front of the optic nerve. Here you cannot create a retinal detachment or a tear. And then she actually, with viscodissection from the back, she did delaminate the membranes from the retina, and the elasticity of this traction actually helps to pull the vitreous anteriorly. I have tried this several times. It works in some areas, and in some areas it does not work. Then you have to go back to your routine technique of delamination, so you don't have to be so strict. The removal of the posterior eyelid can be quite challenging because at the beginning we don't really see it. And we actually did a lot of intravitreal vitrectomy in the first years. We didn't know where, unless it was coated with blood or you had a tractional posterior eyelid in a macular hole eye, you did not really know where it was and what to do. But we have learned that we have to remove the posterior eyelid, and you do it with higher suction over the optic nerve or close to the posterior pole. This is a macular hole case, and you just wait until you see this grayish reflex which comes up, and then you know this is the posterior eyelid, and then you cut it very carefully circumferentially. Don't create too much traction on the periphery. Do you want to add something to that, Moya? Also with this you have to be patient, and patients with synthesis scintillans and floater patients, which become more and more an indication for vitrectomy, they have an attached posterior eyelid in more than 50%. So if you have a synthesis patient, do you know what synthesis is? You think, you know, you have removed the particles already, which you have done, it's clear, but very often behind that, the posterior eyelid is still attached. And then you have to go for that too. So, yes.
Are you doing many vitrectomies for floaters?
No. But I know I'm a good friend with Jerry Sebag. He's the floater person of the world. And I'm not really convinced. If the patient insists and he comes back the third time and he wants the surgery and it's really bad, I might do it. I do very few cases. Because yes, it is. It's now easier and 27 gauge or so. But recently I had a young patient and she insisted of having floater surgery. First eye, perfect. Second eye, I had a bleeding from the sclerotomy exactly at the end of surgery. The blood came in, it bleeded over the macula, so I had to suck out the blood. I did suck out more vitreous. You don't do a total vitrectomy in these floater cases. And I thought, hopefully I'm fine. 3 weeks later, she came, had multiple tears in the periphery, and retinal detachment had already started. So I had to go back in, fix the case, do endolaser and gas. And fortunately, she ended up well. She has now a little bit of a cataract, which she does not care because she wanted to get rid of the floaters. I'm not so happy with the situation. And so I'm not so enthusiastic. But Jerry has great data, how much better they feel in their lives, and the quality of life is so much better if you have removed the floater. And I'm sure the numbers will increase. Yes, please.
There's one difficult case.
Yes.
As it in surgery, maybe every surgery, but you said previously that you don't like the idea of doing floaters.
Mm-hmm.
It's due to that case, or
No.
just
No.
that case not to do it? Yeah.
I think, this was only an example.
Yeah.
And in general, they do well, but it's also that they have in 50% an attached posterior hyaloid. And this is not so easy to remove. They are not technical, and mainly the posterior hyaloid is left if floater surgery is done, and then it comes up later. Jerry Sebag, for example, he's not doing posterior hyaloid removal. He's doing intravitreous removal, and some of these cases, then the posterior hyaloid pops up later, and then he would do a second vitrectomy. It's a philosophy you can follow or not. As I said, I'm not so enthusiastic about it, but I've also learned in my life that you never say completely no to anything. Everything, what we had done in the past and was a no, sometimes 10 years later it starts again. Somebody is reinventing. We will reinvent the buccal surgery. Yeah. And so there is never a complete negative or positive. I just try to be open, but right now I'm not so, I would not recommend it too much. I also do not recommend laser treatment for floaters because I feel it kind of, it does not remove the floaters, but you have, instead of one big floater, you have 100 small floaters, and they do a lot of treatments. They charge the patient at every treatment. So this is a little bit borderline, I feel.
One question.
Yes.
I had a young lady, she went for that kind of surgery to Turkey because our surgeons refused to do it.
Mm-hmm.
She has done on both of eyes. A year later or some months later, she came again to me. She was suffering from the floaters again. I couldn't see any of them. I didn't understand it was just her psychological
Yes.
issue, or it was really because I couldn't see anything, but she was suffering of that, and she was coming and coming and coming again and again. So what's the real, what do you think?
Well, I think, in that case, we have OCT and ultrasound right now.
Yeah,
And
I couldn't see anything.
yeah, and actually we did, in a study, we did also ultrasound examinations for these floater patients, because with the OCT you cannot always see if the vitreous is attached or detached. When we judged, we had two groups. One group of surgeons said it's attached, the other one said it's already detached. So you need, and the distance is sometimes too large to look at it on the OCT, so you have to do ultrasound and see what happens. I don't know. It's if the posterior highlight is still attached, then the surgeon would have to go in back again and would have to dye with triamcinolone to see what's left over. How is her vision? Does she have full vision?
Yeah, she had previously full vision.
Okay.
After surgery.
Okay. Well, I would do the same as you do. I would not do anything, but if she wants to have something done, I would send her back to her primary. So membrane peeling is now in a vitreous surgeon's life the routine, and that you can either use a forceps and pinch or the Tanner stripper. Do you know what the Tanner stripper is? Yes, it's a diamond-coated something which helps you actually to lift the edge of the membrane, and then you can pick it up easier with your forceps. I never use it. I did know Tano very well. He was a great surgeon. And once he gave a lecture at the academy, he always talked about new instruments the Japanese have developed and have. And he presented his diamond-coated Tano stripper. And then a doctor came up and said, Dr. Tano, what are you doing if some of these diamonds are lost in the eye? And Tano was thinking a little bit, and then he said, well, then I would charge $300 more for the surgery. So this was the kind of humor he had. He died several years ago. Some vitreous surgeons have died of heart attacks, I have to say that. It's a surgery where you cannot show your emotions and your tension, so you rather have to put that inwards. And I think this this plays a part in it. But this is the tunnel story.
So you use PGP?
Yes. You know, I use dyes, and actually the videos I wanted to show, because I've actually started to use the intraoperative OCT. We started with that with SAIS 2009. We developed together with them the intraoperative. Do you have one?
We have.
Yes. And you have the size or the size? Yes. So because I felt there is a need to check on the retina intraoperatively, and the video just shows a case of membrane peeling. And I have to say that with the OCT, I felt that I'm cleaner in my surgery than what I normally do in membrane peelings. When I have to give a lecture about how important the OCT is and how good it is, and I have another contra speaker who tells that it's not important and it's too costly, I always lose, you know. And this is a message I would like to transmit. If you invent something new, you are a loser for the first 10 years. Nobody believes in you. If you can present data, you know, phacosurgery was actually like a criminal act for a long time until it was accepted. And it's also that the audience, you think you are speaking in front of an audience who want to try out something new and is so eager. But in general, they are doctors who have their offices equipped. They are not so keen to buy a new instrument for $200,000. So they will not tell you so easily, I would want to have that, or I'm not a good surgeon because I'm not having it. They say, I do fine. I don't need your silly instrument, which costs me a lot of money for a very long time. So, and with the OCT, of course, it's very difficult to do a study to prove how much better the patients can see, but it's really helpful for me, and I think if you can afford it, it's a very good instrument. So here it shows that vitrectomy indications, how they have changed from the 70s with Dr. Machemer's first case in diabetes to trauma, PVR, giant tears. Later, of course, endophthalmitis, uveitis, chronic vitreous opacifications, complications of cataract surgery, tumors. Then membranes, macular hole, RP, primary retinal detachment, AMD and neovascularization, chronic macular edema, vascular occlusions, optic bits, coloboma, vitreous floaters, ILM flap technique, and subretinal surgery for gene therapy. And here we are now, because I'm a believer in cell-derived therapies. I will talk about that at the next lecture. So we have a broad variation for vitreous surgery. It should be included in your spectrum. It's not a difficult surgery. It can be learned easily. It's a non-forgiving surgery. It means if you fail with something or you are not very careful, you will get the result 3 weeks after the surgery. But in general, the surgery itself, just go and do it. Yes, and this is now the video. Does it work? Yeah. Okay. Danke vielmals. So this is the OCT. Only a few of you have it, I see. But it's really nice. and it's integrated into the light beam of the microscope, which is very important. And here, this is a combined cataract and vitrectomy, and the patient had a secondary pucker. So in combined surgery, I always place the trocars first, and then I go for the cataract surgery, so that I don't have to push the trocars and have the fresh wound. And here you see the lens, of course, and the phaco, and you can direct the OCT and control also your cataract surgery. It's also used in cornea surgery a lot. So we developed it for retina, but it's used more in cornea surgery right now. Here you see the phaco machine and the lens implant. And you can judge about the location of the lens. And then you proceed to vitrectomy. And this is triamcinolone for the removal of the vitreous. The endolaser treatment of some tears. Aspiration of the triamcinolone in front of the fovea, and I use the stripper, and now it is the dye. And macular surgery in general I do with a corneal lens. And I really like to be able to see how much I'm tearing, or if I'm clean enough. You see how much traction we actually create when we remove the membrane. And this is now the gas tamponade and the end of surgery. Okay, thank you.
Do you mostly perform in general or anesthesia?
Yes. I know many do vitrectomy in local anesthesia. I prefer general anesthesia. It's also depends on the environment where you work. I always worked in a hospital where we had an anesthesiologist available, and you want also the anesthesiologist to be kept in the ophthalmic surgery, so that they don't go away. So we keep them busy. But also I think it's for the patient, it's more comfortable. I would only do local if it's a 90-year-old patient who would not tolerate general anesthesia.
If patients didn't have any general pathological, you might do local. Yes?
Yes. And this is a second case, and this is a floater. And this was a Chinese gentleman. He insisted of having the surgery. So, sorry? Can you start it? And so I had already removed the floaters, but the posterior highlight was still there. And so I used some triamcinolone to clean this up. And this just shows how adherent the posterior highlight is in these cases. And then I felt not so pleased because I really had to mechanically clean now the foveal area. And I decided then also to remove the ILM. and now I clean the periphery. The case went very well. The patient was happy. But it just tells you that it can turn out as not being so easy than you primarily think. Yeah, and this is an animation of the pre- and post-operative floaters. So, we have a few minutes. Is this okay? Talking about the management of intraoperative complications. So, is there anyone who never had a complication?
Someone who doesn't work at all.
Yes. Why do complications occur? Well, due to lack of preparation, loss of concentration. Sometimes we lose concentration. And yes. And if I have a very hard case and I feel that I get a little bit tired and I cannot focus so well, I go to an area which is easy to do. So if I have something very difficult to separate and it doesn't work and I have already tried different angles and I know I get impatient because I want it, then I go to another area and clean the periphery of the vitreous a little bit more to relax, and then I go back. Lack of desire to be perfect. Okay. Lack of knowledge of perfection. Ignorance to warning signs. This is the most important. You are a good surgeon if you realize a complication ahead, because then you can give the nurse the correct advice, what she has to prepare or what is happening. If you just don't realize that something is going out of order and you continue and they are surprised at what's happening, you are too late in general. And you will be only an excellent surgeon if you have this feeling that this is not going the way it should be, and then you can intervene in time. Very important, without shouting, without throwing instruments, just tell very quietly, because the nurses they will feel the tension. And then you will manage that. Failure to review your cases, good and bad. This is very important. We need to review our cases. Even if you don't publish, you need to know how your personal results are. And this goes for everybody. So, lens touch happens during vitrectomy because while you do the sclerotomy and insertion of cannula, you touch the posterior lens with your instrument. And you never touch it with the end tip. This doesn't happen. You touch it here in the middle somewhere because you focus so much on the opposite side. Yeah? Or what you can do to avoid this, you change the instruments from the right to the left to reach in the periphery, and if you do have to do anterior vitrectomy. How do you prevent it? Well, you leave some vitreous behind the lens, which is, if it's an easy case, and it's a phakic eye, which you should do actually, unless it's a peripheral retinal detachment, then you have to be very clean. Or you indent the periphery, so this can be done by the assistant, that he actually moves the peripheral retina into the center, and then you can remove it. Or you do combined cataract surgery from the beginning to clean the anterior vitreous. So the eye stays soft after placement of your infusion cannula. This is the most uncomfortable situation because the cannula got suprachoroidal or subretinal, and then you see this bulb and the eye collapses, and instead of panicking, you close the infusion line immediately, but also put the infusion in a different site so that the hypotony does not increase. And in general, you put the infusion line in the area of one of your superior sclerotomies so that you fill up the vitreous. Or if you have already a trauma case where you know there's a lot of fibrotic tissue anterior of the vitreous, you simply use a longer cannula here. These are in general 2.5 or 4 millimeters, but also 6 millimeter cannulas do exist. And we use them in trauma with anterior PVR, where we cannot see primarily very well, because this goes always into the vitreous. You are working in a black room, no light, and suddenly the eye gets soft. Yeah. So what can have happened? You check the infusion bottle high or if it's empty. This also happens. Somebody forgot to exchange it. Or the cannula is disconnected or blocked because you have turned the eye and you block the infusion line because the eye is tilted. What is helpful is that you place the cannula closer to the 3 or 6 or 9 o'clock position in small eyes to avoid that. What do I mean? The infusion lines should be not inferiorly at 5 or 6 o'clock, because then you easily tilt the infusion line with your lid speculum. But you place the incisions much more horizontal, and then you have more space for that. If you see that there is a vitreous blocking your infusion line, then you can dissect the vitreous with a lancet or cutter to free it. And finally, if everything works but it's still soft, you check your sclerotomies if there is leakage. This doesn't happen so much more in trocar-guided systems, but it used to happen in the earlier years where we simply did 2 large incisions. High intraocular pressure, the cornea gets cloudy. So there you have to control your machine setting at the bottle high. Sometimes if the assistant is doing heavy scleral indentation to help you, the pressure of the eye rises and you cannot see because there's a corneal edema. So you have to wait a little bit. And if you might see pulsations of the vessels during your surgery, you might have reduced visualization and an unstable anterior chamber in combined surgery. The intraocular lens might come up if the pressure is high, and a prolapse of vitreous. So you have to manage that. You have to reduce the bottle height. You can compress the epithelium with a hot tip to clear the cornea, or you have to remove the epithelium if it stays hazy. And removal of the epithelium, we did a lot at the beginning of the years in vitreous surgery, in diabetic patients where we had a very long surgery and the cornea became cloudy. It's not really a good thing to do. Epithelium heals very slowly. So sometimes then you have these corneal erosions for a long time, and sometimes in diabetic patients they don't clear up at all, ever. So try to stay away from it unless it's totally necessary. And if you have a vitreous prolapse, of course you remove it with cutters or scissors. If you have created an iatrogenic break, this happens. either with the touch of an instrument or you have cut it with the vitrectomy handpiece here. Don't panic. You just clean the vitreous around your tear, and then you laser this tear, and nothing will happen actually. Of course, you should be familiar with your machine and reduce cutting rates. I talked about that. And with the new cutters, it is not very likely, but it can happen. If you have a retinal detachment or you have created a tear and the retina detaches immediately, which is not a very pleasant event, then you still try to clean the vitreous as much as you can. Then you put some perfluorocarbon on it and laser it and remove the perfluorocarbon later. If you have created a hole in the macular area, it usually doesn't need to be lasered at all. They usually close up on their own if you use a gas tamponade. But you have to post-operatively control this area if you might need additional laser treatment. So if you inject some substances under the retina, like dyes or perfluorocarbon, this can happen if the retina is not relaxed sufficiently, or you use this kind of jet stream, and the dyes, they very often, the syringes are clogged because they contain some glucose, and it sticks when the nurse prepares it. So I would recommend that you test out the syringe first, and then you use your dye rather in a soft eye. I always disconnect the infusion line, and then I inject, and this actually rarely happens. So, post-operative choroidal effusion or hemorrhage. Effusion is okay, it's, exudative, it will go away. Hemorrhage is very bad. And what can we do? We feel we have finalized the surgery, we have checked our sclerotomies, the eye, and there's nothing, and next day you see the patient, he has a choroidal hemorrhage. So we have to try to avoid hypotony at the end of surgery, and please, if you are not certain that the sclerotomies are tight enough, you rather suture. It's not a sin. And I know a lot of colleagues are now suturing much more in retinal detachments where they use gas, because you don't want to lose the gas. If the sclerotomies leak, then you close them. And I found some complications in my hands if I had to do second vitrectomies. And the reason was that in the second vitrectomy, I also used small trocars, and everything was fine. But you might go in at the area where the first vitrectomy has already been done, and this is a place where you have some scarring, and the sclera will not be as elastic as you might think it should. And then it kind of opens up, and you can have, I had two horrible choroidal hemorrhages. So in a second vitrectomy, I will close. I will also close if I use silicone oil. If you have a choroidal hemorrhage, you have to go in again. There is no other choice, and you have to do an external drainage vitrectomy with silicone. And the best timing is probably 10 to 14 days after the event. So main postoperative complications, of course, are redetachment, due to incomplete removal of the vitreous or incomplete gas tamponade, which have a high likelihood of PVR. And then you need to use a longer-acting gas or silicone oil, and sometimes add cerclages or retinectomies, unfortunately.